This is Mrs. Harlan discussing Chapter 72, Care of Our Patients with Male Reproductive Problems. The first disease process we'll talk about is BPH, or benign prostatic hyperplasia. It's a common health problem for a lot of men. The exact cause is unknown, but the thought process behind it is the result of a combination of the aging process and the influence of androgens, or male hormones, that are present in the prostate tissue. One such androgen is called DHT, or dihydrotestosterone. As men age and as their DHT levels increase, this causes changes in the glandular tissue and the nodular tissue. And with these changes, there are an increase in the number of cells, and that increase in the number of cells is called hyperplasia. Now, due to this tissue being altered, the body promotes local inflammation, and it attracts cytokines and other substances to that specific area, which allows the prostate gland to enlarge. And as it is enlarging, it starts to cause other symptoms. One of those symptoms is bladder outlet obstruction. As the as the prostate gland is enlarging, it extends upward into the bladder and inward, causing a bladder outlet obstruction. This affects the urinary system in multiple ways. First off, your detrusor muscle, which is basically just your bladder muscle, it thickens to help push the urine out of the bladder and push it past that prostate gland that's very enlarged. Now, despite the fact that the detrusor muscle has grown and thickened to help push the urine out, your patient will still have a residual urine in the bladder, and that's called stasis. And they will also just feel like they continually have to go to the bathroom and will continually have urinary retention. The increased volume of urine can cause what they call overflow urinary incontinence, and that's basically when the man is just leaking out around the enlarged prostate and they're just dribbling. Urinary stasis can also occur, where patients, because they're holding urine in their bladder, it can result in urinary tract infections, and it can also result in bladder calculi, also known as stones. This is a picture of what BPH looks like. You can see that you have all of the prostatic tissue there, and that the urethra is narrowing because of all of that tissue around it, so then that decreases the area that the urine has to come out. Some potential complications of BPH are hydronephrosis, which is an enlargement or a dilation of your kidneys; hydroureter, which is a gradual dilation of your ureters. The prostate is so large that these men cannot void properly, so then they're retaining all of this urine. So that's why the ureters will dilate, and while your kidneys will dilate during this process. And if it is not treated properly, you can continue to have other urinary problems that can lead to chronic kidney disease. So as we look at assessing and diagnosing BPH, as always, I want to take a good medical history. The International Prostate Symptom Score is on page 1501 of your book, and it goes by a number system of whether your particular patient has these symptoms, like incomplete emptying of the bladder, frequency, how often they go, how often do they have nighttime nocturia or having to void during the nighttime, how urgent is it, is their stream weak, are they having to strain to try to get their stream started. So everything is numbered from 1 to 5, and that specific score is added up from 1 to 35, with 1 to 7 being mild and 20 to 35 being a pretty severe case of BPH. As we're doing our physical and psychosocial assessment, these patients are going through a lot at this time, and we want to make sure that we do assess them in a psychosocial assessment. They can be irritable or depressed because of the interrupted sleep if they're having to go a lot at night, because of the annoying trips to the bathroom. It can also affect just the sleep interruption can affect their mood and their mental status. Uh, Laboratory assessment. Always a urinalysis and a urine culture are typically the tests that we see drawn. If there is an infection present, the urinalysis will measure the number of white blood cells, and if that's elevated, it can be typically indicative of either a urinary tract infection. You can also do a CBC to see if it's more of a systemic infection or anemia. And then other tests that we can check for BUN and serum creatinine. If they are both elevated, you usually see that with kidney disease, and these just help us to evaluate the renal function. And then, of course, a PSA. PSAs are used typically to find out where a man is in their lifetime. PSAs were once thought to just specifically be run to see if a male patient had cancer, and that's not necessarily the case anymore. A high PSA is not always a good indicator of prostate cancer, so you must look at the test result along with their history and along with the symptoms that they are having to truly use the PSA as an indicator. Other diagnostic testing that we can look at are a transabdominal ultrasound or a transrectal ultrasound. And with the transabdominal ultrasound, the patient lies on his side. They insert a transducer into the rectum so that they can view the prostate and surrounding structures. I'm sure it's not a very pleasant test for these particular individuals. They can also do a biopsy this way, and with the transrectal ultrasound, they do it approximately the same way. Another test that some physicians will use also is called a cystoscope, and a physician will generally do this in an outpatient setting. They can go in and use a cystoscope. It allows them to view the inside of the bladder neck, and the urethra. It's used to see if there are any stones or how the bladder is made. And you can look in Chapter 66 if you want for nursing care, but just basically know that that test is available if a physician needs to go in and look into the bladder. Non-surgical managements for patients who have BPH. With BPH, most physicians use a combination therapy. There are two classes of medications that are used for BPH. The first one is called a 5-alpha reductase inhibitor, or a 5-ARI, and your 5-ARI is your first line therapy, which means this will be the first drug of choice for BPH. Alpha 1 selective blocking agents are another type of medication that some physicians will use, and sometimes these drugs are used in combination with the 5-ARI drugs. Proscar and Avodart are examples of your 5-ARI medications, and Flomax is an example of your Alpha 1 selective blocking agents. The Alpha 1 selective blocking agents work by basically going into the system and blocking the DHT that is working in the prostate gland. alpha-1 drugs work by relaxing smooth muscles in the prostate gland, and that helps to create less resistance and helps to improve the urinary flow for these particular patients. They also help with peripheral vasodilation and reducing the vascular resistance. The 5-RE drugs work by normally your testosterone is converted to your DHT in the prostate gland by the enzyme known as 5-alpha reductase. By taking a medication that is a 5-alpha reductase, it inhibits that process. Your DHT levels decrease, and it results in that enlarged prostate reducing. There's also acerina repens, which is saw palmetto. This is not FDA approved, so you won't hopefully see a lot of patients on that for BPH. And then there is also surgical management, which we will talk about shortly. This slide shows the transurethral resection of the prostate, otherwise known as a TURP. And a surgeon will go in there and insert a special scope through the urethra, and then they basically into the bladder, and they remove pieces of the tissue from the prostate gland. A couple of complications or things that you may see down the road is because some of the pieces are left behind, you get additional tissue that's left in there, so realize that patients may have to have multiple TURPs during this period. A postoperative care for a TURP, patients will have a catheter placed into the bladder. Some patients may actually have the continuous bladder irrigation, which is where they have large volumes of fluid that continuously go through the bladder and empty out into that catheter. And remember again, the reason why you want this done is so that you get the clots and anything else that is left behind from the procedure. So you really want your drainage to go from a red to a light pink, and that means that the continuous irrigation is doing its job. Also remember, with any type of a BPH, that again the most effective drug therapy is a combination of your 5-RE drugs and your alpha-1 selective blockers. They can help manage all of the specific urinary symptoms that go on with BPH. And also remember that with a TURP and with having the continuous bladder irrigation, that patients will feel like that they have to constantly urinate, so you always want to tell them that this is normal for this type of procedure, and just reassure them that after we get the catheter out and after the continuous bladder irrigation is over with, that this should improve. A couple of reasons why a patient can be a candidate for either a prostatectomy, the entire prostate removal, or for the TURP procedure: urinary retention, chronic urinary tract infections secondary to urine stain in the bladder, hematuria, or hydronephrosis, which again is a dilation of the bladder itself. Prostatitis. Prostatitis can be a very painful inflammation of the prostate gland. You can have acute or chronic bacterial prostatitis. Prostatitis is just an inflammation of the prostate gland. How long it lasts or its presence of symptoms are always indeterminate, and duration of the symptoms and whether you have white blood cells in your urine can help determine what classification of the prostatitis you're in. Bacterial prostatitis can occur with urethritis, which is an infection of the lower urinary tract. The most common organisms that you see that can cause bacterial prostatitis are E. coli, Enterobacter, Proteus, and then some groups of streptococci. With acute bacterial prostatitis, you can see things like fever, chills, dysuria. Some men may have a discharge from their penis, or they may have just a really tender prostate. And sometimes, as a healthcare provider, if you're palpating the prostate, sometimes you can get a discharge with that palpation. Chronic prostatitis mostly occurs in older men. Um, it has a less obvious presentation. You don't have a lot of the systemic symptoms that you see with younger men. Most of the time, they can just experience hesitancy, urgency, dysuria, and maybe sometimes just a difficulty in initiating or terminating the flow of their urine. And there may just be some discomfort in the scrotum or the penile area. For those patients that are a little bit younger with chronic prostatitis, you can see a backache, perineal pain, some mild dysuria and urinary frequency. Hematuria may also be present. Your prostate can feel a little bit enlarged, firm, and again tender. It's possible to see an elevated white blood cell count and a slightly elevated PSA level. A couple of complications of prostatitis are epididymitis and cystitis. Epididymitis is an inflammation of the epididymis, and cystitis is an inflammation of the bladder, which we have talked about in the past. Patients with acute or chronic bacterial infections are more likely to develop urinary tract infections, and their sexual functioning can be impaired because of the pain that comes along with that. The goals for prostatitis are early diagnosis and treatment with antibiotics, specifically antimicrobials. This treatment can last for several weeks or months because antibiotics are not necessarily good at penetrating into the prostate tissue. Certain types of bacterial prostatitis can require hospitalization with IV antibiotics. You want to teach patients that they are at risk for UTIs with prostatitis. Again, treat them with antimicrobials. Bactrim and Septra are two good choices for antimicrobials. Things like sitz baths, muscle relaxants, your non-steroidals, and stool softeners all may help with the discomfort. And then you also want to teach them about certain activities that can also what we call drain the prostate. Those activities are sexual activity and masturbation. Other things patients with prostatitis want to avoid are alcohol, coffee, tea, spicy foods that can irritate the symptoms. Drugs like alpha blockers, such as Flomax, also known as tamoxifen, can be given to help promote voiding. Prostatitis is not infectious, nor is it contagious. Erectile dysfunction, or ED, of course, is the ability to achieve or maintain an erection for sexual intercourse. You can have organic versus functional. Organic is just where there is a deterioration of the function of the penis. The man will notice the firmness is not there anymore, and then they have a decrease in the frequency of erections. Causes can include inflammation of the prostate, surgical procedures such as a prostatectomy, any type of pelvic fractures, neurological conditions such as Parkinson's disease or multiple sclerosis, alcohol, because you have constriction going on, alcohol consumption, drugs, certain hypertension medications can cause an organic ED, and then just the overall health of the individual. Functional ED is ED that basically has a psychological cause. It happens for men a lot of times when they are just really stressed out. men with functional ED usually have perfectly normal nighttime erections and morning erections. It's just throughout the day that they have trouble with those erections. And the onset, a lot of times, like I said, follows a period of very high stress. Of course, you want to do a good history to make sure you know what kind of things the patient is going through, if they're having trouble with their urination, knee pain. The most common intervention for ED, of course, is drug therapy, medications like Viagra, Cialis. Other interventions can include vacuum devices. You can actually go in and inject the medication right into the prostate area. And then also prosthetic devices. Some physicians can do a Doppler test to see how the blood flow is to the penis, to make sure the penis is getting enough blood flow. This lists 3 common drugs, Viagra, Levitra, and Cialis, that you see are the most common for ED. And then again, the 3 things that I just discussed: the vacuum constriction, the injections, and the penile implants. Hydrocele is a cystic mass that's usually filled with straw-colored fluid. It forms around the testes, and it results from your lymphatic system not draining properly, and it causes swelling of the tissue surrounding the testes. The treatment is to do a needle drainage, or you can surgically go in and remove it. Spermatocele is a sperm-containing cyst. It develops on the epididymis alongside the testicle. Normally it's very small. The patients don't have any symptoms and requires no intervention. If it is large enough to cause pain, then you can do a spermatocelectomy to take that off. Varicose is a cluster of dilated veins occurring behind and above the testes. This can cause infertility. A varicocelectomy colectomy can be performed through a small inguinal incision. The spermatic veins are ligated or cut in the cord. And this specific picture shows all of those specific: the hydrocele, the spermatocele, the varicocele. And then this also shows a torsion, which can be, for some men, an emergent procedure. So that's something that must be looked at and evaluated pretty quickly. That is the end of my lecture on Chapter 72.